Chairman, dear guests and colleagues. Thank you for the opportunity to share with you some dilemmas about liver transplantation for hepatocellular carcinoma. Within the confines of time, I will not possibly discuss all the aspects of liver transplantation in this regard. So I wish to refer you to an excellent paper published in Lancet Oncology by Professor Clavien, which is the consensus of international consortium of specialists in the field that covers the topic extensively. I would like to present to you a patient from our clinic, which demonstrates some of these dilemmas. As per the epidemiologic data presented by Professor Shuval, he was born in the former Soviet Union, and he suffers of HCV hepatitis. He had compensated cirrhosis. He was a non-responder to 2 courses of standard therapy at the time, and he was hospitalized with right upper quadrant pain and weight loss. A triphasic CT demonstrated an artery-enhancing mass, which was about 6 centimeters, no vascular invasion or extrahepatic disease. However, the patient was symptomatic and had an alpha-fetoprotein of 12,000 nanograms per milliliter, so he was considered to have a very poor prognosis and not considered for liver transplantation due to the high alpha-fetoprotein, the symptoms, and the size of the lesion. He was offered chemoembolization with yadramycin and lipiodol in June 2006. In September, there was a good shrinkage of the tumor, and there seemed to be some viable area, so radiofrequency ablation was applied to the viable part. In December, 4 months after the presentation, the patient had normal liver function. Alpha-fetoprotein went down to 125, and measured hepatovenous gradient, portohepatic venous, was 10 millimeters of mercury. So he was considered for resection. The resection was performed in December 2006. The surgeon reports that the tumor extended into the diaphragm and kidney capsule, so he dissected those parts. The pathological report found no viable tumor. So the patient was followed up in the clinic. In 2007, the imaging showed no tumor. Alpha-fetoprotein was 14, slightly above the normal level. But a year later, there's an increase in alpha-fetoprotein and a 2.2 centimeters artery-enhancing nodule in segment 8, which goes on to enlarge within half a year and doubles its size, and also the alpha-fetoprotein. There's a controversy about using PET-CT in liver tumors. We were performing a study at the time and what we found in that study, that it was mainly efficient for putting patients off the list by showing tumor thrombi and distant lesions. But the only finding was that avid FDG uptake in this tumor that was 5 centimeters at the time. So chemoembolization was performed for this lesion. And we suggested liver transplant for the patient. However, he declined at the time. And during follow-up, 3 arterial-enhancing small nodules appeared. Ascites developed. Alpha-fetoprotein was around 40, and the patient was started on sorafenib. On sorafenib, the alpha-fetoprotein went down to 11. But this is the imaging. And you can see two arterial enhancing tumors. So the patient underwent liver transplantation. The surgeon describes that the dissection was difficult due to adhesions. And this is the pathological report. There was some 2.5 centimeters well-differentiated hepatocellular carcinoma in the caudate lobe and a necrotic mass with remnants of tumor and no other tumors found. For immunosuppression, he was prescribed everolimus. No strong recommendation can be made for the consensus, by the consensus for these medications, though at least some preliminary studies suggest efficiency in preventing recurrence of hepatocellular carcinoma after liver transplantation. And this is the clinical course. As you can see, he did pretty well, and until there was an elevation of liver enzymes. He was biopsied and found to have recurrent hepatitis C. And he's been on therapy since, with quite a good response, viral and biochemical. There's been some discussion about the potential of antiviral therapy to prevent relapse of tumors, but the recent meta-analysis suggests that interferon therapy may have some role in preventing recurrent hepatocellular carcinoma. So, as you can see, this patient presented some serious dilemmas regarding the therapy of hepatocellular carcinoma. As previously discussed, it is a multifocal disease in a precancerous environment. So liver transplantation is definitely the best surgical radical resection and also cures the underlying disease. However, in the first year, it was applied without discrimination, and the prognosis was far worse than for other indications of liver transplant. So raising the question whether it's an ethical procedure for the general population, but not for the patient that survived. Therefore, better criteria were needed, and these criteria were based on the tumor stage, with the liver function and the functional status of the patient, which is based on the tumor size, number of nodules, satellite lesions, vascular invasion of any kind, and metastasis. As mentioned before, BCLC is the preferred staging system to assess the prognosis of patients with HCC before therapy, and TNM is the best system for assessing prognosis after liver transplantation. About the diagnosis, it was previously discussed, so we use sectional imaging. And there are the criteria for listing candidates with HCC in cirrhotic livers for liver transplant, for cadaveric liver transplant. The consensus stated that this should be reserved for patients who have a predictive 5-year survival comparable to non-HCC patients, which is based on the preoperative assessment of the size of the largest tumor or total diameter of tumors. We should regard the alpha-fetoprotein. And currently, the Milan criteria are the benchmark for the selection of HCC patients for liver transplantation. The Milan criteria, which describe either a single less than 5 centimeters nodule or 3 nodules up to 3 centimeters, were found to have a prognosis of 75% survival at 5 years with less than 10% recurrence, as illustrated by the work of Mazzaferro in New England Journal of Medicine. However, when people looked retrospectively at the earlier experience, and mainly at the University of Pittsburgh experience that transplanted basically everybody, they found that at least 20% of people that do well are discriminated against by these criteria. So there is a search for extended criteria, some of them being the UCSF criteria listed here. And you can see that there's a relationship between the size and number of tumors, and that can be taken into account to predict more or less the survival of the patients. And the same review assessed a number relative to the risk of recurrence. Basically, there's a huge difference between more or less than 10 lesions. Also, there is the metro ticket that puts both criteria on a line and shows that there always is a chance for the patient to benefit from transplant. So the question whether 20% survival is good in an incurable oncological patient, it definitely is. The discussion is ethical about the other candidates. Outside Milan criteria are surely worth discussing. Amongst the criteria that are shown to correlate with the prognosis of survival and recurrence are microvascular invasion. They cannot reliably be assessed before the surgery, but they definitely correlate with the number of nodules and the size of the tumors, also with the histological grade. All of them information that is not available generally prior to surgery. Macrovascular invasion is a definite contraindication to liver transplant. So there is the role of downstaging to be discussed. I have seen many people uneasy about the patient being transplanted, but there is quite a serious amount of work that shows that downstaging a patient and taking time to look at the biological behavior of the tumor may allow a proper selection of patients with good prognosis after transplantation. So the criteria for successful downstaging should include the tumor size and the number of viable tumors. Alpha fetoproteins should be taken into account. And there should be enough time allowed to see the biological behavior of the tumor, which is at least 3 months. So what can we do for our patients on the waiting list? As you know, organs are very scarce in Israel. We should watch them carefully. Very small tumors, there is no information so far that they can benefit from any procedure. But the T2 tumors are likely to benefit from neoadjuvant therapy, like local regional therapy, that can be either chemoembolization or RF ablation. And there really is not enough data to decide which is best, so we probably should stick to the technical availability. Livers are allocated according to priority scores. MELD is accepted in Israel. Many HCC patients have MELD scores that definitely disadvantage them, so we do allow them extra points. The exact amount of points that should be allowed should be tuned once in a while, because we all know that there was a time when we only transplanted tumor patients, and then we adjust these allocation at certain times of assessment. Is there a role of living donor liver transplantation? Well, as far as the patient, if the recipient is concerned, definitely. There always is a chance that he may benefit. Well, there are some centers that practice some sort of extreme surgery. So I had a patient transplanted abroad from a relative that basically had even vascular invasion. And surprisingly, he did quite well until he died of a heart attack. So the patient always benefits. The problem is with a donor. We know there's about 1 in 200 mortality and at least 40% complications. So this is an ethical issue to be discussed. How about the post-transplant management? These patients should be definitely monitored for recurrence of tumors by half-yearly CTs or MRIs. About the prevention using mTOR inhibitors, there really isn't enough data, but there seems to be a trend. And I think this is a practice of many centers, at least is the practice of our center. And if the tumor recurs already, then we can treat it by the same methods. But liver retransplantation is not appropriate for recurrent HCC. How about our own experience? We had 40 patients transplanted for hepatocellular carcinoma in our center. They were 80% male, and there were 19 deaths in this cohort, but only 6 due to recurrent disease. These are the patients out of the 441 that had tumors. Only 6 of them had recurrent hepatocellular carcinoma, and on pathological examination they were mostly beyond Milan. With better staging, we hope to avoid these cases in the future. So how can you better assess the patient's prognosis and allocation of therapies? The future probably lies in the genes and more sophisticated techniques. This is just one of the papers that looked at the gene expression signature that determines vascular invasion. Basically what you do is you make a gene expression and run it on a chip and analyze the patterns. And you can see the performance, which is outperforms all our previous data that were the size and number of tumors. And there's been the HCC transcriptome classification that might have significance in prognosis, but also in determining the best therapy for the patient. So in summary, liver transplantation is the best option for cure of HCC and underlying liver cirrhosis. The patient's prognosis before and after liver transplantation is also determined by the underlying disease. This patient had hepatitis C. I might remind you that hepatitis C survival is about 60% at 5 years. Careful assessment and management pre and post-op are required. Better characterization of the tumor biologic behavior is expected to improve the management. The ethical dilemma between the patient's best interested and the society's value due to scarcity of organs and the risk for living donors should always be considered. I thank you for your attention.